Yeah, don't think for a moment we're on a content drought. I already have the next set of videos planned out. It just so happens that we are slaves to the algorithm, and React content is very meta now, so I've decided to check out one of the more popular videos in pharmacology on YouTube, that being speed pharmacology, and let's see what they got right here.
In this lecture, we are going to cover pharmacology of antipsychotics.
Very difficult topic.
So, antipsychotics are a class of drugs used primarily to treat psychotic disorders, such as schizophrenia, mania due to bipolar disorder, and severe depression.
Right. Not just severe depression, it's not just, we have to clarify that, because for unipolar depression, they're used as add-ons, but for bipolar depression, they can be used as, although it's difficult to use them as like monotherapy. Oftentimes in bipolar depression, you get like layers of drugs. But yeah, that's generally, yeah.
Now, in order to gain better understanding of mechanism of action of antipsychotic drugs,
interesting graphic.
First we need to discuss the role of dopamine in the development of psychosis.
Dopamine. Yeah. So we there's been a lot of discourse recently of the monoamine hypothesis. I'm curious how they're gonna approach this actually.
So the monoamine neurotransmitter, dopamine, plays a key role in the so-called dopamine hypothesis, which argues that the unusual behavior and experiences associated with psychosis can be largely explained by changes in dopamine function in the brain.
Okay. Yeah.
Now, dopamine has four major pathways by which it affects the brain.
Classic
Number one, the mesolimbic pathway, which is thought to be hyperactive in schizophrenia and to mediate positive symptoms of psychosis, such as delusions and hallucinations.
Yeah. I think Psychopharm, the YouTube channel, made a better, well, not necessarily better, but a more comprehensive framework where they talk about the mesolimbic pathway, which I incorporated in my videos also, is that yes, dopamine does mediate positive symptoms here of psychosis, but at the same time, mesolimbic pathway, that includes the ventral striatum nucleus accumbens, also does play a role in addiction, rewarding behavior. So perhaps dopamine here may be better seen as mediating salience. So it's a case of psychosis, salience with regards to which stimuli we would perceive as relevant or we'd perceive at all, and or which beliefs, for example, we would provide salience to. And that salience would also cover, of course, aspects of reward and later on secondary negative symptoms. But this is speed pharmacology, right? I mean, that's why I have the long form YouTube content, and then there are other channels dedicated to short form. And I do respect the ability to like crunch this very technical topic, like people like Arshi have been trying to do into just very bite-sized pieces. That's especially for a topic like antipsychotics, it's very difficult.
Number two, mesocortical pathway, which is thought to be underactive in schizophrenia and thus mediate negative psychotic symptoms such as loss of motivation and social withdrawal.
Yeah. Here is where a lot of people often stumble, is that oftentimes they would classify psychosis, schizophrenia as like too much dopamine. But then you forget there are other parts of the brain where you have the same receptor doing different things. So this is very essential psychopharmacology if you look at the basics, right? So mesolimbic, excessive neurotransmission there, but mesocortical, you have deficient. So it's not just blocking the excessive activity in mesolimbic pathway, because it's the brain. If you send a drug to the brain, it's going to hit all of that. If you block mesolimbic, you're also going to block mesocortical. So, that's a challenge, right? So they do a good job here.
The nigrostriatal pathway, which is part of the extrapyramidal nervous system and controls motor function and movement.
Yep.
Deficiency of dopamine in this pathway can lead to dystonia and Parkinsonian symptoms, while excess of dopamine can lead to hyperkinetic movements such as tics and dyskinesias.
Wait. Let me just review that part a bit. They're saying
hyperkinetic movements. Well,
you have deficiency of dopamine, Parkinsonian, excess of dopamine can lead to hyperkinetic movements such as tics and dyskinesias. I was trying to review the pathophysiology actually of tics as part of our practicum in clinical psychology. Of course, I try to be very thorough with these things, and I don't think we've really seen anything definitive. Yes, we do use dopamine receptor antagonists for tics, but just because it works for tics, does it mean that there is an excess of dopamine with tic disorders? It's like saying, yeah, SSRIs work for depression, but that doesn't mean that there is a deficiency of serotonin in depression. So those are two very separate things. So we can't really making leaps. Like, it's very tempting to. I understand it's very tempting to, especially in a very compact video, but we can't be making leaps of logic like that, right? There's still a lot we don't know actually on the tic side.
Hyperkinetic movements such as
Like-
tics and dyskinesias.
Especially when you start talking about things like tardive dyskinesia. So you start talking about receptor density, upregulation, things like that, supersensitivity, and all. So, right?
The last major pathway, number 4, is the Tubero infundibular pathway,
All right.
which controls prolactin secretion.
Right. Straightforward enough.
Specifically, dopamine in this pathway inhibits prolactin release.
Yeah.
And as a reminder, prolactin is a hormone that enables milk production
Right.
and is also involved in the control of sexual desire and regulation of immune system.
Yeah, so pretty straightforward there, right? So just gotta remember, nigrostriatal, Tubero infundibular, they're not really affected in, schizophrenia or psychotic disorders in general. It's only when you give the drug things start happening.
Now, within those different pathways, dopamine interacts with specific receptors
Right.
that mediate functional effects of dopamine. There are 5 primary types of dopamine receptors, known as D1, D2, D3, D4, and D5.
Yeah. The current drugs we have, I just tend to ignore everything except D2. Although, there is some interesting preclinical research, no doubt, for the other receptor types. But so far, I'm kind of like a reverse flow kind of person. I'm not because sometimes there's so much hype about new mechanism potentially leading to improvement in clinical outcomes. But me, I'm kind of the reverse. Show me the clinical outcomes first, and then I'm gonna get hyped for that new mechanism, baby. Yeah. Okay, so I'm kind of like the opposite there. So like for now, it's just really D2 that you really gotta pay attention to.
Out of the 5, D1 and D2 receptors are
Yeah.
found in the highest density in nearly all of the pathways involved in psychotic disorders.
Right.
However, D2 receptors are the
D2,
most clinically
see, there you go,
relevant
basically.
because they're the main targets of antipsychotic drugs. Now, antipsychotics
Okay,
can
grouping.
be grouped into older, first-generation agents known as typicals, and the newer second-generation agents known as atypicals.
Right. So I'm gonna pause here because this is a very it's still technically correct in the sense that it's kind of what we use a lot, right? But I just want everyone to avoid falling into that trap that all the atypicals have these properties, all the typicals have these properties, because as you will see, that's not really the case.
The first-generation typical antipsychotics all share the same main therapeutic goal, that is to block D2 receptors.
Right.
Furthermore, typical antipsychotics are not selective for any of the 4 dopamine pathways, and thus will block
Right.
D2 receptors in almost all areas of the brain.
Pretty much, yeah. I mean, it's like throwing you drop food dye into water. It waters the brain. You can't just expect the drug to diffuse into just mesolimbic. It's gonna hit everything. You can't stop that. Our technology's not advanced enough to like localize it to just one part of the brain yet. Wouldn't that be nice though?
This has positive as well as negative consequences. So, blockade of dopamine receptors in the mesolimbic pathway reduces positive symptoms,
Yeah.
such as delusions and hallucinations,
Yeah.
which is beneficial.
Right.
However, blockade of dopamine receptors in the mesocortical pathway
Right.
that is already underactive in schizophrenia
Right.
may cause worsening of negative symptoms
Right.
and thus lead to diminished energy, lack of motivation, restrictions in emotional and verbal expressiveness, and social disengagement.
Yeah. Take note, this may also actually be a result of blockade of D2 receptors also in the mesolimbic pathway, because there are is that neuroleptic induced deficit syndrome? It's a more technical term, but basically secondary negative symptoms can result. So it's kind of, it's again double-edged sword. Mesolimbic, mesocortical, block D2 receptors there. Yeah, less positive symptoms, but yeah.
Furthermore, blockade of dopamine receptors in the nigrostriatal pathway may lead to extrapyramidal disorders,
Yeah.
tardive dyskinesia, and Parkinson's-like symptoms,
Yeah.
such as tremors, muscle rigidity, and difficulty in starting and stopping movements.
Yep. Just take note, tardive dyskinesia takes a while. So like the first, the akathisia, Pseudoparkinsonism, acute dystonias, those are relatively like within weeks. You'll start seeing them, but for tardive dyskinesia, about months to year or so before you start seeing those.
Lastly, blockade of dopamine receptors in the Tubero-Infundibular pathway may cause increasing blood prolactin levels, which then may lead to galactorrhea, gynecomastia,
Yes,
and sexual
gynecomastia.
dysfunction.
Thank you. Because people forget about that. So again, it's not just women who are affected, also men. Right? So gynecomastia, breast enlargement in men. It's possible, yeah.
Now, based on their affinity for D2 receptors, typical antipsychotics are often subclassified as high potency or low potency.
Yeah. This can be a helpful classification, or you can also do the chemical group classification if you have to deal with all of them. But in the Philippines, we only have 4 plus 1, right? So it's easy to just remember those 4 and the plus 1 as a separate entity altogether. Because even in other countries, it's just a separate thing altogether, really. Right?
The examples of high potency antipsychotics are haloperidol, flufenazine, prochlorperazine, and trifluoperazine.
For instance, we don't have trifluoperazine. I'm not sure if we have Prochlor. I have to double check on that, but I have to double check. Anyway, but generally, just the main things we use there are just 4.
Potency
right?
antipsychotic is chlorpromazine.
Yeah.
So generally speaking, the high potency agents produce stronger antipsychotic effect at relatively low doses.
Right. Again,
However,
emphasis on that, at relatively low doses. They're not saying they have a stronger antipsychotic effect. They're saying you just need a lower dose to get the desired effect. Versus the low potency, you need a higher dose. But at the therapeutic doses, generally everything except clozapine, they work the same. Equally effective. Except clozapine. Yeah.
They also tend to cause more extrapyramidal side effects and greater increase in prolactin levels.
Right. Oh, the prolactin thing, that's a very interesting bit. I had to correct myself on that. So I made a mistake here. Yes, high potency antipsychotics seem to produce more EPS than the low potency ones. But when you talk about prolactin elevation, it seems in terms of frequency, whether high or low potency, they seem to be producing the same incidence of hyperprolactinemia. I'm not sure why. My hypothesis is maybe T2 receptors, they are more sensitive in the Tubero-Infundibular pathway in the pituitary, but what we've seen in clinical references, generally same incidence there.
On the other hand,
and I had to check 3. I made sure it's not just I was looking just at one book. I had like 2 books and 1 database to 1 book, 1 clinical practice guideline, and 1 database to verify that they were all saying the same thing.
Less selective low potency agents do not bind to D2 receptor as tightly as the high potency agents, and generally affect a range of other receptors, including alpha-adrenergic, cholinergic, and histamine receptors.
Yeah. Don't let this make you think that high potency doesn't bind to these receptors. Okay, they do, but just lower affinity. So it is still possible to exceed the side effects related to the blocking of those receptors for the high potency ones. But it's like you're gonna see it a lot more with chlorpromazine. Basically, you're gonna see it a lot more with chlorpromazine.
This can result in a variety of side effects. For example, blockade of alpha-adrenergic receptors can lead to orthostatic hypotension.
There you go. Straightforward.
Blockade of muscarinic receptors can lead to anticholinergic symptoms, such as dry mouth, blurred vision, difficulty urinating, and constipation.
Hopefully you're familiar with this by now.
And blockade of H1 histamine receptors can lead to sedation and some weight gain.
Yeah.
Now let's move on to the second generation atypical antipsychotics.
Okay.
In contrast to
Here we
typical
go.
antipsychotics
We're talk about
that primarily
atypicals.
block only D2 receptors, atypical agents appear to block both D2 receptors as well as serotonin receptors subtype 2A.
Yep.
Because serotonin inhibits dopamine
There.
release.
You see, I see that figure that like this is from Stalls. This is very Stalls. So that's why compared to like how others approach antipsychotics, this is relatively more in line with the general consensus of antipsychotics. Because Stahl Foundation right there. Stahl baby, woo!
Agents that block serotonin receptors may increase dopamine levels in brain areas that need it. Furthermore, atypicals occupy D2 receptors transiently and dissociate quickly, allowing for relatively normal dopamine neurotransmission. This modest D2 receptor blockade in combination with serotonin receptor blockade is thought to significantly lower the incidence of extrapyramidal side effects, as well as decrease negative symptoms and improve cognition.
I have to qualify two statements there. Number one, not all have a lower incidence of EPS. That only works for, some. But there are like a select that have higher rates of EPS, right? And number two, negative symptoms, only secondary negative symptoms are addressed, not primary. Okay, so far, unless again I've seen emerging data that this might change based on the interpretation of clinical trial data, current consensus is that no antipsychotic is efficacious for primary negative symptoms. How do you differentiate? Again, primary is from the disorder itself. Secondary is due to the drug. So you will see less negative symptoms from second generation. Okay, and but they still cannot address the primary negative symptoms. You just need to qualify because those misconceptions are very embedded.
Compared to typical agents.
Yeah. That's why I don't like using typical atypical. You lose that nuance, right?
Examples of atypical antipsychotics are aripiprazole, clozapine, lurasidone.
We don't have lurasidone.
Quetiapine, risperidone, and ziprasidone.
We don't have ziprasidone either.
Now, in addition to dopamine and serotonin 2A receptor blockade, atypical antipsychotics also bind to many other targets, including other subtypes of serotonin receptors, as well as histamine, alpha-adrenergic, and muscarinic receptors.
Yeah. Just to qualify, sorry, I have a lot of comments, but I guess if you're watching this, that's what you're here for. You might see in the newer edition of Stults, the 5th edition, that chlorpromazine actually and the other first-gen so-called antipsychotics, they also bind technically to the other receptors. So what's the deal here? The deal might be that when you talk about second-generation so-called antipsychotics, it's not just the parent compound that binds to these receptors, but also their metabolites. For the first gen, apparently their metabolites don't really have an affinity for the serotonin receptors as much as, say, second gen. So that may be another reason, right? And of course, the primary reason being affinity, relative affinity. So second gen, third gen even, they have higher affinity for 5-HT2A relative to the D2 receptor. Oh, sorry, I skipped ahead.
As a result, the side effects of second-generation agents can vary depending on the drug's receptor binding profile.
Yes.
So, for example, atypical antipsychotics that have strong affinity for serotonin receptors subtype 2C, such as clozapine and olanzapine, may cause metabolic side effects, including weight gain, hyperglycemia, and dyslipidemia.
Yep.
Agents that have strong affinity...
Wait, it's not just clozapine and olanzapine. Technically, clozapine, olanzapine, quetiapine, risperidone, they all cause metabolic side effects. So, it just so happens, why is it clozapine and olanzapine that are boxed? Because they have the highest risk. Okay, highest risk. But quetiapine and risperidone, they can actually affect metabolic parameters even at low doses. That effect is not dose dependent. We're not even sure. We're not sure if it's just 5-HT2C or in tandem with H1. It might also be the M3 receptor. It might be a mystery receptor. We don't know. But again, it's not just clozapine, olanzapine, right?
Affinity for H1 receptors such as clozapine, olanzapine, and quetiapine may cause sedation and may also contribute to weight gain.
Yeah, the pins. But again, take note, risperidone also is an H1 receptor antagonist, just to a lesser extent. So, just because you don't see risperidone boxed for H1, doesn't mean it's not going to cause sedation. It's still going to be sedating, but not as bad as the pins. Talk to anyone who's been on a pin, clozapine, olanzapine, quetiapine, it's really like knockout. But risperidone can still be sedating to an extent, alright? So, again, there's some nuance there.
Agents that have significant affinity for alpha-1 adrenergic receptors, such as clozapine and risperidone, may cause orthostatic hypotension.
Yep, and quetiapine. Quetiapine actually has high affinity for the alpha-1 receptor, whereas it also is metabolite. Regardless, still, you could see a lot of orthostatic hypotension with quetiapine. Olanzapine, I have to double check if there is as much. I'm not sure about that one.
In addition to that, out of all second-generation agents, risperidone seems to have the strongest affinity for D2 receptors.
Right, there we go.
Because of that, it has the highest potential to induce extrapyramidal side effects.
There we go. Thank you, Speed Pickle. Okay, I love you, Speed Pickle, because again, this is something that's missed when you start using the typical atypical atypical differentiation. Risperidone. You look at again at the middle 5 letters there. Perid. It's basically derived from haloperidol. Very potent D2 antagonist. So risperidone, paliperidone, even amisulpride, they can cause EPS. So that basically renders the typical atypical distinction useless. Essentially, it makes things confusing if you do it that way.
Lastly, clozapine is the only antipsychotic that can cause serious condition called agranulocytosis that occurs when the bone marrow does not produce enough white blood cells called granulocytes. Because this condition can be fatal, periodic blood cell counts must be performed to ensure patient safety.
Not in the Philippine outpatient setting. Well, some do, but a lot don't. Not as strict as US or UK. But agranulocytosis, let me just again remind everyone, that is the least of your worries. Potentially fatal constipation, myocarditis. There are a lot more things to be concerned about with clozapine than agranulocytosis, I'm saying. I mean, regulatory framework, yes, white blood cell depletion is the boogeyman for clozapine, but there are just, from a clinical perspective, there are so many more things higher up there to be worried about clozapine, right? So, yeah, just some context.
And with that, I wanted to thank you for watching. I hope you enjoyed this video, and as always, stay tuned for more.
Yeah, that was a good video. So again, poor pharmacology is to poor therapeutics, and it seems the foundation here is a lot better than like from a lot I've seen. So, I guess I'm just a very detail-oriented person, you know, some stuff to iron out. But overall, it was really good. It's hard to pack all of that into 8 minutes. So you know what? Kudos to Speedpickle for doing that. I placed a link to the video in the description below. Please watch it and don't watch it from here, so they get the views. You know, I'm just here to farm React Meta algorithm views. I'm transparent about it, right? So until the next video, whatever that will be.